Hi, my name is George Scaff. I am a PGY2 resident at Riverside Community Hospital, UCR School of Medicine, and my case is called the root of the triple threat: mitral valve rupture, RA thrombus, and a submassive saddle embolus. Introduction to this. It has been shown that the prevalence of valvular disease in SLE can be more than 50%, most common form being mitral valve prolapse, making about 25% of cases in SLE. Hypercoagulability is also common with antiphospholipid antibody syndrome in 30 to 40% of SLE patients. Rarely, very rarely, hypercoagulability can cause a right atrial thrombus. The case description. The patient presented a 56-year-old male, past medical history of SLE, to the ED with 2 days of progressive shortness of breath, lower extremity edema, and orthopnea. And he hadn't been on his SLE medications for the past 2 years due to lack of associated symptoms. His previous symptoms were generalized weakness, malaise, and he stopped feeling those, and so he stopped the medication. And he came into the ED. Labs were significant for a BMP elevation of 1700, troponin of zero point 0.2. COVID PCR was negative. Cardiology was immediately consulted after PE findings of an apical holosystolic murmur. They did a transthoracic echo, which revealed a mitral valve rupture, and they subsequently performed a transesophageal echo, which had shown a right atrial thrombus. And you can see it on the echo on the left. This is just a still image, but the actual image is very cool. You could actually see the several clots, what seems to be several clots, bouncing around the RA chamber. So when that happened, a hypercoag panel was ordered, including antiphospholipid antibody, anticardiolipin antibody, and the whole coag panel was negative. A left heart cath was done, showing clean coronaries, severe mitral regurgitation, and heart failure with reduced ejection fraction. CT surgery was consulted for mitral valve repair. They ordered a CTA of the chest more so in preparation for the procedure, but incidentally, they found a saddle embolus, and the saddle embolus is pictured on the right. Patient was hemodynamically stable at the time, and the ICU doctor, going off of a Moffitt trial, used a subtherapeutic dose of TPA, which has been shown proven survival benefit in patients with a submassive PE. And he was started on warfarin with a heparin bridge. Repeat CTA was done prior to discharge and didn't show any evidence of pulmonary embolism. And he was followed up, and CT surgeon wanted him to come back in 3 weeks for the mitral valve replacement as outpatient. But he was readmitted the day before his surgery because of increased shortness of breath and leg swelling. He was then medically optimized in the ICU, and the next day went on for an intraoperative TEE, showed no right atrial thrombi, and mitral valve repair with minimal complications. They also got a biopsy and sent it to pathology. Path report came back, myxomatous degeneration, cultures were negative. According to the CT surgeon, when I curbsided him, no evidence of any ligament sacs, endocarditis. He thinks that this was all caused by a history of mitral valve prolapse. Post-op course was complicated by atrial fibrillation that was ablated within 24 hours. And this case shows multiple potential cardiac complications of SLE, including the mitral valve rupture, mitral valve prolapse, possible history, atrial fibrillation, and hypercoagulability causing the right atrial thrombus. Unfortunately for him, the importance of taking medications even in these asymptomatic SLE patients is highlighted here. Also, the great importance of a good cardiac exam, which may have potentially saved him this egregious course of in a previously healthy 56-year-old male, if they were able to detect the mitral valve prolapse on cardiac auscultation prior. And that's my case. Thank you.